There were those falls, and little by little it started to look like balance issues. We tried everything. At one point, we thought there was nothing else to be done. She saw an ear, nose, and throat specialist who focuses on balance disorders. She had an MRI, but the first time nothing showed up. It was only this last time, in January, that the possibility was raised. No one had ever mentioned this condition before, not even her primary care doctor, who is a geriatrician.
Normal pressure hydrocephalus, or iNPH, is a chronic neurological condition that is still misdiagnosed. It has been described since the 1960s, and we think that about 2 million patients live with iNPH in Europe today, but only 13% are diagnosed and operated. It's difficult to diagnose because sometimes it can be thought as just growing old, or it can be mistaken for an Alzheimer's disease or a Parkinson's disease. But it's unfortunate because normal pressure hydrocephalus is a reversible cause of walking and gait disturbances. Today we're going to take you with us throughout a full day of normal pressure hydrocephalus testing. The patient is going to undergo a neuropsychological evaluation, then she will have gait and walking testing, then she will have a lumbar puncture, we will re-evaluate the walking after the lumbar puncture, and she will undergo an MRI. The first step of the day is the neuropsychological assessment. It will allow us to examine attention, memory, and executive functions.
The goal of a neuropsychological assessment is to evaluate cognitive functions, especially memory, executive function, language, and processing speed, as well as behavior and emotional state. In normal pressure hydrocephalus, we often see subcortical disorders, a general slowing of both thinking and motor responses, and problems with executive function, including flexibility, inhibition, planning, and attention. Apathy is also common, showing up as loss of initiative and reduced interest, leading to less activity in daily life. We sometimes see emotional blunting, or even emotional indifference, where patients show little or no reaction to positive or negative events. The severity of these symptoms can vary. This pattern in normal pressure hydrocephalus is different from what we usually see in neurodegenerative diseases, which more often affect semantic memory, for example, memory of events in their context, as well as orientation in time and space, language, and the ability to reproduce movements.
The results of the neuropsychological examination will give us food for thought, and they will be linked to the rest of the evaluations that will be done during the day. The second step of the day is the evaluation of gait and walking parameters. Our physiotherapist will take the patients through the different steps of the examination.
In normal pressure hydrocephalus, or NPH, gait and balance problems are often the first visible signs. They may come on gradually and subtly, but they're very characteristic. What do we see in physical therapy? Patients often have a shuffling gait with a widened base of support. Whenever you're ready, let's begin. In other words, they walk with their feet farther apart to stay balanced. We also often see difficulty starting to walk or changing direction. Shall we try again? The tests we use are simple but validated ones. The 10-meter walk test, the timed up and go test, and the 30-second sit-to-stand test. We collect many quantitative data points: time, speed, number of steps, and combine them with a qualitative video analysis. This allows us to spot more subtle changes in gait. Ready? These tests help us objectively assess motor problems and see if there's improvement after the lumbar puncture. Afterward, we have the key indicators to decide on next steps, including whether a shunt may be recommended.
The same test will be repeated a few hours after the lumbar tap to be able to evaluate if there is any change after the evacuation of CSF. Lumbar puncture involves removing a certain volume of CSF. In normal pressure hydrocephalus, we consider that the main pathophysiological cause of accumulation of CSF is an increased resistance to the flow of liquid. And when this resistance increases, the volume of CSF will increase, probably being the cause of the disturbance of the walking parameters and of the other symptoms of iNPH. When we do an LP, it's a diagnosis test and a therapeutic test, because it will allow us to see if the patient will get better afterwards. There is a common misconception that LPs are extremely painful or uncomfortable. When patient is installed correctly, when we are in a comfortable setting and under local anesthesia, an LP can be perfectly well tolerated. Three hours after the LP and 24 hours after, we will repeat the same walking tests and gait tests we did in the morning to be able to evaluate any significant changes. Even small changes are important for us to note, and we take into consideration also the quality of the walk, not only the quantity of the steps or the gait speed.
How do you feel when you walk? We've just repeated the tests after the lumbar puncture, and we can already see an improvement in her gait. Transitions are smoother, turning still takes several steps, but arm swing is preserved. And she's now walking the same 10 meters as this morning, but faster. In the 30-second sit-to-stand test, she's improved by 20% compared to this morning. That's a very encouraging result before the final evaluation tomorrow.
Once these initial steps are completed, the patient will undergo a specific MRI that is designed to look specifically at CSF and CSF distribution around and inside the brain. In the ventricles, that will be enlarged, but also in the subarachnoid spaces, where we can see that we have a disproportionately enlarged subarachnoid spaces.
Radiologists can play several roles in the care of patients with normal pressure hydrocephalus. Neurologists, primary care doctors, and sometimes neurosurgeons refer patients to us when NPH is suspected. Sometimes patients come for an MRI because of balance problems or other symptoms, and it's during that scan that we spot warning signs. The first thing we look for is hydrocephalus ventricular enlargement. We must first check if it's caused by an obstruction. Is something blocking the flow of cerebrospinal fluid, causing the ventricles upstream to enlarge? If no obstruction is found, we then look for signs and point specifically to NPH. The first is what we call ballooning of the frontal horns. We measure the distance between the ends of the frontal horns and on the same slice, the widest distance between the parietal bones. This gives us a ratio known as the Evans index. If this index is greater than 0.3, it can indicate hydrocephalus, and we then look for additional signs. Another key sign is callosal angle narrowing. We measure the angle formed by the corpus callosum. If it's too narrow, less than 90 degrees, that supports the diagnosis of NPH. MRI technology is now very advanced and can provide more clues. In addition to morphological sequences that show the brain structure, we now have functional sequences. One example is the CSF flow sequence, which lets us measure the pulsatility of the cerebrospinal fluid. Hyperpulsatility is another sign pointing toward NPH. So in summary, as radiologists, we look for both structural and functional signs. We confirm that yes, there is hydrocephalus, but no, it's not caused by an obstruction or simply brain atrophy. Once we've ruled those out, we look for the subtle clues I've just mentioned to guide the patient to a neurosurgeon who specializes in NPH.
At the end of the day, the patient is given a subjective form that he will fill out for a week, giving us his own impressions. How did he feel after the LP? I will see him 2 weeks after to put together all the information we got from the assessment day to be able to give him a precise and clear diagnosis, and when iNPH is confirmed, be able to give him the opportunity to have a surgery, which is a VA or VP shunt that can be potentially life-changing. For many of our patients, this assessment day is the first day where they start getting better and probably on the way to having better quality of life. Because early diagnosis can be life-changing, let's talk about normal pressure hydrocephalus.